which would be much better. But it's also great that with this technology, we can actually hear what John has to say. So I'll pass over to him at this point. Thanks very much, John.
Thank you, John. Can you hear me, everybody? Am I coming over loud enough? Somebody say yes or no.
Yes.
Okay, great. Okay, well, the title I've been given to work to is Privatisation for the NHS, Toxic or Tonic? And obviously it could be a very short one, because I can't imagine anybody here in today's meeting would be thinking it's a tonic, and therefore we just end the discussion there. But I think what I'm going to do is try to look at all the evidence, of course, over the last 40 years, is that whatever forms of privatisation has been tried, it's actually proved to be a failure, and quite often damaging to the very standards and quality of care that the NHS can actually deliver to patients. But I think it's useful to look at three things that spin out of this title. Firstly, what are the main forms of privatisation, and how far have they progressed, or what's happened to them at the current moment? What is the current state of play? How many services are contracted out or privatised? Is the private sector booming, as it keeps claiming, and as in fact ministers keep claiming as well, apparently? And how useful is it to the NHS, if at all? And how can we get a balance between campaigning on privatisation, which obviously is very key? It's what Keep Our NHS was set up to do 20 years ago, and obviously it remains central to our work. But as the crisis the NHS develops, which John touched upon, we go into a winter where headlines are going to be about a number of other things as well. How can we get a balance between campaigning on privatisation and fighting on the integrity and actually keeping an NHS that actually can function, rather than simply on the question of privatisation itself? And obviously privatisation kicked off as I got involved first. I didn't do it, by the way, but my first encounter as a full-time campaigner on the NHS began in 1984, in the spring of 1984. And the very first steering committee I went to at the London Health Emergency, which was set up and funded back then by the GLC in the glory days when you could get local government to pay for campaigning and set up bodies to actually lead campaigning. Back then, the very first meeting I went to of the steering group of London Health Emergency was discussing the Barking Hospital women's strike, or the Barking strike rather, against privatisation, against being outsourced, their jobs being outsourced to a company called Crothall. And the famous phrase was, you get F-all from Crothall. And they were fighting a contract which meant they were going to get reduced hours of work. They were going to be required to do more work in those hours, and they were going to get less pay for those hours as well. So it was an all-round hit coming from privatisation. This was pre-TUPE days. This was when the new contract could actually simply discard all your existing terms and conditions. And it was a long fight. It started almost simultaneously with the miners' strike, and it went on a good 6 months after the miners' strike ended. Although, of course, what everybody read about in the headlines tended to be the miners' strike and not this fight for people to remain in the NHS and to protect what was vital to those services. And it's useful to look back at those early days. There was a whole wave of strikes against the outsourcing of services, privatisation back then. And all of them, mainly cleaning staff, but there were some catering staff and laundry staff also involved, because those services were also the first ones to be outsourced. And what emerged from all of these was the agenda for driving through the privatisation was not universally supported. In fact, large sections of NHS managers didn't agree with it at all. They felt they was losing control of the services in their hospitals if they contracted services out. So it was by no means a uniform process across the country. And but it ticked a number of boxes for the Thatcherite agenda of those days, 1984, mid-peak Thatcher. So it was separating hotel services, as they called them. In other words, the things that were not directly clinical care from clinical care, and suggested somehow these were less the business of hospital management than the actual direct clinical care of patients. Although, of course, the hospital managers didn't do the clinical care either. So this was a bit of a specious argument. And of course, for those who actually wound up at the sharp end of this, for nurses on the wards to have cleaning staff that was now employed by private companies and responding to them and their contract. It meant that all the jobs that then suddenly weren't being done by the cleaning staff, and the hours that the cleaning staff weren't there, the nursing staff wound up doing that work instead. So it was actually far from a gain or an efficiency for the NHS staff at the front line. But secondly, it created this two-tier status within the NHS. Ancillary staff, non-clinical staff became effectively a second-class group of staff. And it therefore assisted in dividing the NHS workforce, which was also assisted by the anti-union laws, which Thatcher had put through in the early 80s. And of course, this meant that now if you're employed by a separate employer, that your pay negotiations, everything else was separated out from the negotiations on other staff. There had just been a whole rolling strikes in 1982 right across the NHS that had been effectively led by the more unionised ancillary staff and followed in many cases by nursing staff. And this would ensure that unified action wouldn't happen again for a prolonged period, if at all. And so that was also part of the Thatcherite agenda, weakening the unions, undermining the unions, breaking up the organised and bargaining strength of the workforce. It also ticked the neoliberal box of scaling down the state because it's part of a cuts in spending on these services, allegedly delivering more efficient services, but in practice actually doing less work, as I'll mention in a moment. And so I think that there were all these arguments, and of course there was it was all part of this argument that the private sector was somehow inherently more efficient than public sector provision. Somehow, if you wanted a job done, the mark of excellence was the private sector doing these things. And of course, what we discovered very quickly, as soon as any of these contracts actually began, you could see that was clearly shot out the trees as an argument, because the quality of care went right down. By 1987, the National Audit Office did some investigation of the first rounds of outsourced services and found that the savings that they made were three things: reducing the amount of services delivered, in other words, reduced frequencies of cleaning and so forth, with the reduced hours and numbers of staff were being reduced; reducing the labour costs in the sense that they're actually cutting the hourly rates and so forth, and also cutting the numbers of staff, and increasing productivity, which is a polite phrase of actually forcing staff to work much harder to do the same work with fewer staff in fewer hours, and all to the benefit of the private employers. So that was actually, again, demolished the argument that in any way was this actually delivering an improvement of efficiency. Only in catering was there a degree of new technology brought to bear that actually improved the productivity of those frontline staff. So quite a lot of those arguments, sadly, the arguments of the benefit of privatisation, the argument that competition being brought in to compete for these contracts was somehow going to ensure that you're going to get better value for money. These arguments were actually embraced not only by the Thatcher government in other NHS changes, but also by the Blair team that actually took over the leadership of the Labour Party in the 1990s, and of course won the election in 1997 and opened up a new period there. They bought into this argument. Somehow competition was actually a better way forward. That somehow the private sector had lessons to teach the public sector on how to run things efficiently and effectively. And of course, we all know where that wound up during those periods of new Labour government. So it's interesting to remember, looking back, because the extent to which NHS employers resisted the idea of outsourcing their services right in the 1980s, despite the fact there was all the pressure from government, who kept changing the goalposts, shifting the rules that applied to try to make it more and more compulsory for competitive tendering to take place, and for it to be based on the lowest price bid, regardless effectively of the quality of the services that were going to result. But also it's worth remembering all the way through this whole process that when we talk about this type of privatisation, this is not selling off the NHS. This is actually contracting out services. So the private contractors that took these contracts, and quite often only held them for a few months before they were chucked out on their ass for failing to deliver, these private contractors never at any point owned part of the NHS. Right? It's not sold off and privatized in the way that British Gas or the water companies were actually split up between shareholders and now form private property. It was the NHS choosing to deliver some of its services via a private supplier. I think it's really important to remember this because almost all of the forms of privatization we're discussing, with the sole exception, I think, of PFI, are in this category. They are contracts. They have a defined life. Once those contracts come to an end, they can be brought back in-house. They could even sometimes be brought back in simply because the supplier has failed to deliver. So it's important to recognize that, because we're not simply looking at something as fights that we've lost and therefore it's gone forever. We can actually recapture even the services that have been privatized. And that's one of the reasons that Keeping NHS Public exists in the first place, is to pull it back in-house and return our NHS to public control and ownership. Yes, it's also important to realise in the privatisation process of the ancillary services, the support services, the NHS lost many of the most experienced and loyal staff who just couldn't face the idea of working under the conditions established by the new employers, were disgusted by the fact they weren't going to be able, given the hours, to do the job that they'd spent so many years, in many cases, already doing. And they wouldn't be able to have time to work and have a relationship with the patients in the wards and so forth. So what was lost was part of the ward teams that helped to make the clinical staff more efficient, helped to make patients' lives more acceptable on the wards, helped us provide someone who could talk to patients in terms they understood, even perhaps where nurses and doctors couldn't do so. Sorry, I'm heavily dosed up with day nurse and it dries my mouth out as I'm talking. So hence the now then. Yeah, so that layer of privatisation was certainly no tonic for the NHS, but neither was it toxic, because in a lot of cases, these failed contracts were brought back in-house. And when we get to 2024, last year, when I did a roundup for a couple of small unions who wanted a report on the whole history of privatisation to put before the COVID inquiry, when I looked at those figures, it discovered that 55% of the sites cleaned in the NHS are done in-house as of 2024, in-house. So we get the illusion that all of these things have gone and they've gone forever. But actually, there's been a shuffling. Some have been in and out. Some have always remained in-house and so forth. So even when we had the dispute earlier this year with, or last year with the East Suffolk and North Essex Trust at Colchester Hospital, where they were trying to outsource staff who had been brought back in-house in 2012, and they were trying to outsource them again. This is a constant process, and the fight can be won to pull them back in-house. This has not gone forever. We've also had, of course, in the more recent period, we had a whole series of really large privatisation, cleaning and support service contracts in the mid-2010s, 2015, 2014, 2016. A lot of those that were drawn up, Leicester, Nottingham, a couple of others, where the contracts went south really quickly, really went off and were very exposed very quickly. And the lesson has been drawn that actually this is, in most cases, this is not the way to go. So we've had two different variations come out of that. One is that a considerable number of trusts, particularly in London, have brought outsourced services back in-house, and a number of those since COVID, but others earlier on. Imperial and a whole series of other trusts have brought their quite considerable numbers of outsourced staff back in-house. And there's just been a fight by the GMB in Epsom and St Helier Trust in South London to actually get those staff who've been brought back in-house, get them properly put back onto Agenda for Change, the national pay scales of the NHS, because they brought them back in-house and left them on the same wretched terms and conditions of the privatised employer. But again, this shows that these fights can be taken on and the process can be reversed. So, yes, so the other model that has also emerged was the attempt to set up wholly owned subsidiaries, subcos, which the trusts would actually hive off their own staff into these companies that would be run by the trust, allegedly as arm's length bodies. But in practice, they were able to cash in on a loophole, which meant they could claim back a lot of VAT that they would otherwise have to pay. And this was basically an elaborate tax dodge. But also it did mean that when new people were brought into a number of these subcos, they would come on inferior terms and conditions to the people already there. And that again offered the possibility of longer term savings. And there was a whole wave of these in the run of just before COVID. And then during the COVID pandemic period, a lot of NHS managers recognised the value of having in-house staff and being able to work directly with in-house staff, the loyalty that they showed and the way that they were prepared to work. This more or less came to a pause. And then since that, we've now most recently had a directive from NHS England to stop doing it anymore. No, there should be no more subcos set up. I think this comes along with the fact that the Treasury seems likely to change the rules this year or next year on whether the VAT is any more reclaimable, in which case the whole tax dodge thing falls apart and the whole value of having the subco pretty much collapses. So again, they've tried to work around it and try to get the best of both worlds. But the reality is that the best model, the most efficient model, time and again has proved to be the in-house model for delivering these services. I mean, the other really big area of privatization, which really is privatization because the private sector actually owns something substantial for a prolonged period of time that the NHS doesn't own, and that is PFI, where the private sector puts the money up to build new hospitals and facilities for the NHS and then effectively rents it back, or the NHS pays effectively for it over installments over the next 25, 30, 35, in some cases 40 years. And of course, this has proved an incredible money train for the gravy train for the private sector, and huge amounts of money have been paid. I think this is one area where campaigners, and I think I spotted Greg Dropkin in the audience there, campaigners like Greg have actually really succeeded. I mean, PFI, I think, has been made into effectively a dirty word across the NHS. I think we have, all those years in which we fought to expose what it really meant, what the real costs were, what the impact was in the NHS. I think that really has gone home. And obviously in 2018, it was compounded by the collapse of Carillion, the big PFI company that was building the Royal Liverpool Hospital, where Greg had fought so long and hard for against the PFI funding of that hospital, but at the same time also managed to save the NHS millions of pounds by actually challenging the original deals and actually forcing a reconsideration of those deals. And Midland Metropolitan and the Liverpool hospitals were still incomplete when Carillion went bust in January 2018. And that has created shockwaves through the Tory party, which of course had originated the idea back in 1992. And Philip Hammond, who was then the Chancellor, if anybody remember him, under Theresa May, anybody remember her, decided that there would be no more PFI. Now, and that was still applied when Boris Johnson came along with a legendary promise of 40 new hospitals, which is still getting echoes of laughter around the country as everybody tries to work out where anybody's ever going to see a new hospital in the foreseeable future at all. But anyway, even when he made that promise, it was clear that that was going to be publicly funded. The question was, where was the money? And of course, that's never been answered. But nobody at that point or since has actually concretely suggested PFI as the way to fund those hospitals. And I think there's so many examples around the country where still multi-million pounds a year are funneling out of trusts into PFI contracts for years still to come. I think there's going to be a lot of heavy lifting for Labour to try to roll that back, how much they might want to revisit PFI again. Now, we're coming on to clinical services now. This was a new Labour invention. Thatcher, for all that she outsourced and privatised during her period of government, never actually privatised clinical care at all. Even during the internal market was set up and virtually nothing was contracted out outside of the NHS. It created competition and a bureaucratic market within the NHS, but it didn't create that was within the NHS, not outside. And it wasn't until New Labour came along, and from 2000 with the NHS plan, Alan Milburn's NHS plan, started the whole process of opening up the NHS budget to private providers who could offer to deliver certain services. And the very first area that this started to take form in practice was in 2000 with the Concordat. This was the deal with the private hospitals that could take NHS-funded patients particularly during winter peak periods for elective operations, and could charge through the earth for them. Through the NHS paid through the nose, an absolute fortune. In some cases, 40% above the cost of delivering the service within the NHS. And so this was something that the trusts absolutely hated, but which the private sector obviously saw as a very handy way of filling otherwise empty hospital beds with somebody who's going to pay something, and quite often very effectively, almost effectively, the whole private tariff for those beds. That was an extremely expensive experiment, and the trusts have gone out of their way in most cases to avoid that happening again. But that was followed on by various other forms of private delivery. So there was the diagnostic and treatment centres. In particular, there were scanner services where Allied Medical would drive these lorry. You could literally get your scan off the back of a lorry under New Labour, these scans would be taken by privatised staff in privatised lorries, and then they'd be sent around the world to different electronically around the world to be read by consultants elsewhere and come back with the findings. And this was somehow regarded as a more efficient way than actually funded the NHS to expand its scanner services and its existing radiography departments and radiology departments. And so this again took place. It does seem some of this has been institutionalized. The last time I had to go for an MRI, it was literally in the back of a lorry in a car park in I can't even remember where it was. I think it was Coventry, but it was nowhere near the main hospital. And it was actually seemed to be plugged into a local health centre. So this is still going on. You just get referred to a unit, and it's not until you turn up you realise it's got a name other than NHS on the side of it, and you're actually being dealt with in this case by NHS staff in a unit that's been leased by the NHS. So again, the argument for this being more efficient or more effective than the NHS is a rather difficult one to make, because we don't actually, we don't know what the costings would have been to simply expand the numbers of NHS scanners, which has remained chronically low compared to other countries. NHS scanners, and of course the staff to work them, and employ them directly through the NHS as part of a bigger department. I would think in almost every case you would find that to be more efficient and more effective as a service. But anyway, they've followed on the independent sector treatment centres. Some of you may remember those as well. This is the private hospitals that were effectively built up by overseas companies. The initial theory was that this wouldn't use any NHS staff. Companies would have to come in and bring their own staff with them. So we had the ironic situation where you had an ophthalmic, an eye hospital unit, a treatment centre set up in Oxfordshire, one of the wealthiest countries in Britain, and it was staffed by people from South Africa who'd come over from the private company there to actually deliver cataract treatments and eye care in Oxfordshire at the expense of the local eye hospital. And there's now a campaign ongoing in Oxford to defend the eye hospital, because so many of the cataract and routine operations are being contracted out to private providers. It's making it very difficult to sustain the training and the delivery of services in the eye hospital, which is part of the Oxford University Hospitals Trust. So I think these things continue to be problems for us, although actually in many cases the peak of their delivery and the peak of their rollout has long passed. There are so many things wrong with these treatment centres as a theory. They were never open to competition. the contracts for these treatment centres was restricted always to only to the private sector. NHS trusts and foundation trusts couldn't apply for them. So this immediately limited the possibility of it actually being any real competition, and just meant the private sector could carve up the market between themselves. And they also, despite the initial assumption they'd all bring staff from abroad to work in them, most of them immediately started hoovering up staff out of local hospitals and effectively denuding them of the staff they needed to deliver their own services. And it became pretty obvious that that was going to be the way it was. And the second round and third round of ISTCs, they actually said, well, you're free to recruit staff, but they need to be additional to the NHS. But I mean, this clearly was never the case. So what you get with the expansion of privately provided NHS services is a zero-sum game. You have more private provision, but at the same time, it limits what you can do through the NHS. So this is a crazy situation where you're actually paying money out, making a profit to the private provider, you're paying more to the private provider, and yet at the same time, you're not actually getting the benefit you could if you spent the money directly within the NHS and expanded those services. Also, in this whole period, you had the emergence of foundation trusts. Now, they're not privatized, but they were set up to be the nearest thing within the NHS, or nearest NHS type thing to a private company that Alan Milburn could get. In the end, it was all pruned back by Parliament. He pushed through an original plan that they would be registered at Companies House and be completely autonomous and able to borrow money without any approval from the NHS, and not be answerable to the NHS organisations locally or nationally, but only directly through their board of governors to Parliament. And this wound up, obviously, most of these things were stripped back. Despite Labour's majority, the backbenchers fought this very hard and limited what they could do. And it's interesting, Labour now is talking about a new form of even more freedoms for foundation trusts to be brought in. And we can guess who's moving that, as Alan Milburn has been brought back into the Department of Health and is part of the forces actually shaping the latest thinking, such as it is from Wes Streeting and Labour ministers. But that again is something that happened in that period. And again, the argument was these foundation trusts, they were going to be brilliant, innovative. They were going to be taking, they were going to be, what's the word, entrepreneurial. They were going to be actually expanding their private wings and generating income. They were going to be doing all kinds of things. At the end of the day, Parliament said, quite correctly, the majority of Labour MPs forced a change in which most of those initial powers were stripped away. And what we've seen in the years of austerity since is that effectively the foundation trusts, which might have started out stronger financially than the other trusts, foundation trusts effectively has wound up as dependent on bailouts as all the other trusts when the NHS has hit problems. Now, all of these, what we have in common with all of these forms of privatisation or steps towards facilitated privatisation is that they're using NHS funds to buy the services. The private sector, insofar as it's expanding with the use of NHS money, but that money funnel, it comes through contracts. Those contracts can come to an end, those services can be brought back in-house. The NHS itself hasn't been sold. And I think this is just really important to keep track of. The only area where the NHS has been effectively sold off, or property of value, substance has been handed over, or the NHS has been curtailed to make way for the private sector, is, well, the two areas: PFI, which comes to an end when most PFI contracts come to an end, and who knows what's going to happen then with some of these buildings. And the other area is social care, because of course long-term care of older people used to be a property of the NHS. I used to have geriatric wards on hospitals with specialist geriatrician staff and specially trained nurses. And that, of course, was bit by bit wound up as the Thatcher government pushed through reforms, the community care reforms, so-called back then, which actually handed those services over to private nursing homes. And so what we've had is a massive expansion of private nursing homes, the loss of that expertise and that provision within the NHS. And that is an outright privatisation. And that does mean when it comes to sorting that problem out, it's a lot more complicated than simply switching a contract and bringing services back in-house. There is a huge issue there about the fact that a large proportion of the actual service delivery is in private hands and would have to be nationalised, and it would actually be a big step to do so. So there's a big problem about reversing that in terms of social care. I should just touch also on primary care, because this is another interesting example. The private sector at various points in the 1990s, in the 2000s, attempted to move in and take over numbers of GP practices and actually expand into primary care. We saw it in 2004 with the United Health, which bought its way into some GP contracts in London and a couple in Derbyshire. Mysteriously, goodness knows why they chose Derbyshire. I've got nothing against Derbyshire. I don't know whether they had, but it was really strange. One in a mining district in Derbyshire, where they just tried to buy up a GP practice. What was interesting was, first off, that all the appeals against the logic of this, that who could expect the largest of the US insurance companies to really have the remotest interest in the welfare of the people in a mining village in Derbyshire, there must be something ulterior motives in there, but the judiciary refused. There was a judicial review of this, and she was thrown out by judges who said, no, it's perfectly reasonable to hand this contract over to the company. But at the end of the day, there was not enough profit there for them to hang around, and they left. And this is what's happened again and again with the privatization of GP services. Companies think it might look quite a good idea. And of course, on one level, GP services do seem to be almost a halfway house with the private sector, because the GP partnerships are effectively small, self-contained businesses, except that for the last, whatever it is, 75 years, they've actually been part of and effectively run as part of the NHS. So when the private sector, private companies, and we've had a number of them try to buy up chains and so forth, the profits coming out of this are never very substantial. And we've had, most recently, of course, Centene moved in. Well, we had Virgin moved in and out, and Virgin Care has effectively given up the ghost and decided to sell off, having failed to make any significant surpluses out of any of the projects it took on. And we've actually had also now Centene, the American giant insurer, that's come in, bought up a whole load of GP surgeries, and also moved back out again when they realized again the profits were nothing like what they can command in the US, and therefore not part of their business model as they see it. So it's interesting. The private sector has very limited areas in which it's got an interest in taking over the NHS. And it's important to remember that as well, because we can spend a lot of time shouting alarms about things that aren't going to happen. And one thing that's definitely not going to happen is the private sector taking over emergency services. I think seriously taking over elective services. I think taking over a lot of services where there's actually very little prospect of any significant profit forthcoming. And given the general level of funding is so low for the NHS here in comparison to many other countries, the spending per head is much lower than most European countries and so on. The idea that this is going to be an attractive target for the US to come in any meaningful sense, I think, is highly questionable, which is a nice thing to think about when you look at what's going on in other parts of the world. Yes, sorry, I'm just trying to bring it up to date now. Right, I just want to move on because Labour, of course, as we know, since July last year, when Labour got elected, there has been an increase in the use of the private sector, and you know that is significant, but it's not a uniform increase in the use of the private sector, and I'm really quite surprised about that. and also the extent to which that is now privatized. So just for the working for the lowdown, I hope some of you do look at the lowdown. It's online, it's free access news and information, evidence-based news on the NHS. And we just took a look at the latest NHS figures on the proportion of services that were delivered by private sector organisations. And this was from July. And in July, the two biggest areas are ophthalmology, which is easier to read than to say. Ophthalmology, which is basically cataract operations and the various outpatient appointments related to that. Ophthalmology is the biggest area because you hardly need more than a kind of a fairly clean office to actually be able to deliver that. You don't need a full hospital, and the private sector has found that quite easy and cheap to invest in. So it's a big area. But in July, of all the ophthalmology work, only 22% was done by the NHS. That's according to NHS own figures. And orthopedics is the other area, the hip replacements, knee replacements and so forth. Again, a staple of the private sector. In July, 20.5% was done privately, according to the NHS own figures. That means 78% and 79% are still being done by the NHS after years and years of trying to drive through greater use of private sector providers, and in the middle of a situation where you have a very large NHS waiting list. So this is not seen by many parts of the NHS as a better way to actually deliver elective care. And Labour has pushed up the use of private providers by 10% overall since last year. But actually, that's an overall figure. But there's very huge local variations. So in Southeast London, they've increased the use of the private sector since last July by 71%. 7 out of 42 integrated care board areas in England increased the private sector use since Labour was elected. But 5 haven't changed. 7 have reduced use, and the largest of them cut by 26%. So overall, it's quite remarkable. There has not been that huge surge in privatisation I think a lot of us expected from all the statements of Wes Streeting and co in the run-up to the election, insisting that the private sector was somehow the solution to the NHS. And one of the reasons that's the case, well, there's several reasons why that's the case. Firstly, it's the limited scope of the private sector to deliver anything other than the simplest operations. Now, that's a big limiting factor. A lot of people on the waiting list have more complex needs than that, and therefore they're not candidates for using private sector providers. So that I think is an overwhelming factor. But also the NHS bodies themselves obviously are keen to protect the viability of their own organisations, and they're reluctant to send more people to private operations if it's going to take the money and the resources and, of course, the staff out of the NHS to do them. So the overall picture in July was that there was 6.6 million NHS appointments and 500,000 private sector. 6.6 million NHS in-house, effectively publicly provided, 500,000 private sector, and which has gone up 51% since July 2019. So it is an increasing trend. There's no doubt about that. Only 2% of that private sector caseload were inpatients, actually in hospital beds, and 14% of them were day cases. So 84% of these are outpatients. So a lot of those will be diagnostics for scans and so forth, rather than directly for any further treatment. So the question is this really such a decisive contribution to the NHS? And there was a recent government press release, which I think is quite interesting on this. I was quite surprised. There was a whole wave of stories, and I thought there must be a common source to this. At the end of October, I think it was October the 26th, I think it was. At the end of October, a wave of uncritical articles proclaimed the increased numbers of NHS patients with outpatient appointments or being treated in private hospitals and clinics. And it said there was a vital role being played by the private sector. And this came from the Department of Health. And the government's figures showed that the private sector was delivering 5.2 million NHS-funded outpatient appointments in the year to September 2025. That's 100,000 a week. But the most recent NHS figures, if you compare that with the whole NHS, shows that's less than 4%. So, which is 140 million on the NHS. So is 4% really vital and decisive? This is really the question that excuses it and makes it worthwhile. The release goes on, the press release went on to say 988,000 patients receive treatment in private hospitals or clinics. 19,000 a week, that is, across well, I mean, I can't remember how many private hospitals there are now. I think it's something, anyway, 19,000 a week. All of these are elective cases because the private sector has never wanted to do any emergency work whatsoever. And in the nearest comparable period, the NHS treated 18 million admission episodes of elective treatment and of course, all of the emergency cases as well. So in this context, the private sector is clearly not playing a vital role or a key role, even though they're playing an additional role because of the eagerness of ministers to send patients through the private sector rather than invest in the NHS. And I think this is the key point. The private sector can expand some of these services relatively easily because they have discretion over how much capital they invest. So if they can see a profit can be made in it, they can expand those services in a way the NHS can't, because the NHS has to go through the government to get the capital. And this has been the constraint all along. This is why there's been an incentive to use private providers. So in other words, it's the cuts in capital, it's the cuts to and the austerity limits on NHS spending that actually drive the role of the private sector and increase that. And I think that's really worth noting. 2 seconds. I'm in the final stages now. You'd be glad to know. Yeah. So, the other question is, what's the state of the private sector itself? Is it actually a booming sector? Is it doing well? Everybody assumes that in the aftermath of COVID, when the NHS waiting list almost doubled, went up from 4 million or so to 7.5 million in that period after COVID. Surely that must mean lots of people are getting fed up on NHS waiting lists and paying to go private. And in the first quarter or so after the peak of COVID, there was a sudden leap of people, the self-pay patients, going through private hospitals. And it went up from something like 50,000 a quarter to 70,000 a quarter. And people are saying, well, this is just the start of it. There's bound to be a surge in those patients. Everybody must be digging into savings and borrowing money from friends and whatever in order to go private. That's not the case. It's more or less plateaued at 70,000 a quarter ever since for the last 2.5 years. It's stayed at that level. And why is it at that level? Because it's very, very expensive to go private and because the private sector can't treat all of the things that people actually want. And if you're on an NHS waiting list, you've already got a pre-existing condition. So it's too late to take out private health insurance to cover you. So the reality is that the private sector isn't the easy bolt hole that people seem to assume it is. And I think this is, again, really important. When we come in to defend the NHS, this is an NHS which is genuinely for everybody, because it doesn't matter how much money you've got in your pocket. There is no private emergency system if you have a heart attack. There's no private emergency system if you get knocked down by a car in a major car accident. There's no no private health system will take you on without you paying an absolute fortune. For elective care, but they won't take you on at all for emergency services. This is a service for all of us. And when we come in to defend the NHS, I think this is an important aspect to keep hold of. Right, so obviously, and finally, so with all this in mind, when we look at the state of play, that the private sector, despite we had Thatcher We had Thatcher followed by Major, which continued the same policies. Then we had Blair and the New Labour policies, which have further extended privatisation. Despite all of that, we come out the other side, and we have, even in the areas where the private sector has made most inroads, we still have a large majority of the services delivered in-house by the NHS. So I would contend that while it's still an important aspect of our fight, because we have to prevent further loss and just waste of resources, sending people privately when the NHS is far the most efficient and effective way of delivering services, it's not the only thing we should be campaigning on. And when we come into this winter, we're going to have headlines, I think, right across this winter about the number of elderly people stuck for hours on end on trolleys in A&E. We've already had a few over the summer. People stuck for days on end in some cases. It's shunted off into corridors where they're forgotten about and so forth. Just really horrendous cases. And we're going to get lots more of those, I think, across the winter. And that's going to be an issue where if we're as campaigners are not talking about that, if we haven't got that central to what we're saying, I think we're going to be seen by a lot of people as not really on the case. So I think it's really important that while we continue to fight on privatisation, we continue to see it as a threat to the NHS, that we also maintain a clear grip on the other issues that are coming down the line, which are really serious. And that involves, as I say, the A&E, but the whole question of the scale of the waiting list and the really glacial progress that's being made on reducing it, which means that Labour's nowhere near solving this problem and moving forward. One of the core reasons for that is because the beds are being blocked by emergency patients, because there's not sufficient social care and community-based care outside hospitals to help patients be discharged once they've been through. So we need a whole process of looking at a system to make the system work so that it can actually cope with the levels of demand that are coming through. The Royal College of Emergency Medicine reckons 8,000 more beds are needed to get the NHS back down to a level of bed occupancy that can ensure we eliminate all the long delays of patients coming in and being stuck for hours on trolleys or being stuck in ambulances outside waiting to come in. They reckon that can be done without building any new facilities if we just made sure we could actually discharge 60% of the people who've been stuck in hospital for over 3 weeks or more because there's no support for them outside. So I think campaign for a system that really does tackle that, I think would be something that would find an echo, because everybody knows somebody who's been stuck in this system at one point or another in it, or is now lumbered with the inferior social care or the lack of support outside hospital having been discharged. And I think that's an important area for campaigning. The other thing is the state of our buildings, which is impeding productivity in many, many trusts as well. The state of NHS buildings has just gone downhill so rapidly, and it's frightening. We've now got the most recent backlog maintenance bill is in excess of 16 billion. We've got so many hospitals, I forget how many it's, with over 100 million pounds worth of backlog maintenance. We came very close to having the first £1 billion backlog maintenance trust in Imperial College in London, which has got a couple of hospitals that are effectively falling down. And we have to actually have a fight on that as well. How can the NHS really hope to deliver state-of-the-art services when the buildings are collapsing around people? There's no point in putting a new computer in to actually then have the building collapse on top of it. So let's make sure we get the basics right. GP services are a continued scandal. The training of professionals is, again, all the gaps are being opened up now and exposed by the junior doctors challenging the lack of jobs for up to 20,000 junior doctors seeking to move through the system and develop their careers. And these things all need to be thought of on, not just privatisation. I think that's really, really important. And it's part of our fight. Keep Our NHS Public was set up to fight privatisation, but not only to fight privatisation, to fight for it as part of the fight for the NHS to go forward. And that's why we continue to use that phrase, keep our NHS public. But let's keep it all, and let's keep it better, and let's maintain it and improve it, and let's expand it so that we can actually eliminate the private sector once and for all and keep our NHS public. Thank you very much.